The anatomotor is a multi-purpose roller massage table equipped with 2 sets of semi-pneumatic back rollers that cover a 24-inch area of the spine. It can convert for assisted or standalone manipulation. Adding traction can create a dynamic and effective all-in-one treatment table. The spring-mounted rollers depress with about 30 pounds of constant pressure. This reduces the possibility of traumatizing your patient. The anatomotor is easy to operate. For heat, just press the red switch. To turn on the vibration, push the yellow switch. To start the table, select the desired treatment time, usually between 7 to 10 minutes, and set the switch to either the cervical or lumbar position. 2 handles control the roller height independently. Each pair of rollers straddles the spine. Thus, individual adjustments can be made to treat kyphotic or lordotic curvatures. The motor mounted inside the frame sends gentle vibration and heat up through the back rollers. To secure the roller position, palpate the rollers against the patient weight and push the lock to the left. Pressure on your patient should be comfortable but firm. To release, simply push the lever to the left and the lock will disengage. To increase the roller height while the table is in motion, move the handle towards the next higher number while holding the lock until it clicks. To use the anatomotor as a standalone treatment table, flip the switch to cervical and insert the filler block. The rollers can also be raised to create a loaded spring breakaway during manipulation. When you begin a massage treatment, position your patient so that the full spinal area is in the tabletop opening. Flex the patient's legs to flatten the normal lumbar curvature. In this way, the rollers provide more continuous and equal pressure to the lumbar region. The table will now glide back and forth just under the normal respiration rate, moving the patient over the rollers at about 8 cycles per minute. This rate is most effective in inducing relaxation. Several specific manipulation techniques are easily performed on the anatomotor. The bottom set of back rollers can be lowered completely and the top rollers are then raised 2 or 3 numbers. The top rollers will now have the same fulcrum effect as placing your hand or fist behind the patient. For a general dorsal correction, apply manual pressure to your patient as they glide towards the head or cervical table position. Release this manual pressure as the patient moves back to the foot or lumbar end. For a lumbar sacral separation, raise just the bottom set of back rollers as a fulcrum. Bring the patient's knees to the chest and apply mild pressure as the patient glides towards the head end of the table. The rollers don't always have to work on each side of the spine. For treating just one side of the upper thoracic area, use the upper set of rollers. Raise the patient's arm and rotate their position to one side. This is a very effective way of working trigger points along the scapula and lower cervical area. The bottom set of rollers can also be raised to work one side of the piriformis. The moving top can be used for assisted passive range of motion and stretching. The leg rollers are designed to massage any area of the legs and can be used simultaneously with the back rollers. The leg roller bar easily inserts into any one of the 4 different positions. Placement of the rollers may vary with the patient's height and the area to be massaged. For hamstrings and lower buttocks, insert the roller bar in the slot nearest the center of the table. To massage from just below the knees to the ankle area, normally the bar would be placed in the second slot up from the foot of the table. Massage of the popliteal space where veins are close to the surface of the skin is not advisable and can be avoided by positioning the patient higher on the table. To reduce the massage pressure on either hamstring or calf areas, simply support the heels with a pillow or the insert block. Leg rollers should not be used on patients with phlebitis, severe varicosity, or any other condition for which deep kneading massage is contraindicated. For mild cases of edema, leg rollers may be used to encourage venous drainage. Rest the patient's legs on the rollers as the table glides to the foot end or lumbar position. Then raise the patient's knees as the table returns to the head end. This will push blood and lymph away from the ankles. Patients can easily learn to do this unassisted. The leg roller bar is also useful for passive hip and knee exercise. The slot position in the side rail determines the degree of knee flexion. Generally, it's advisable to start in one of the two slots closest to the foot end of the table. Set the table switch to the lumbar position and determine how much flexion the patient can tolerate. To increase or decrease flexion, move the leg roller bar up or down or adjust the patient's position on the table. If the timer is set at 10 minutes, the patient will receive about 80 knee flexions. The Hill anatomotor can deliver either intermittent or constant traction. For lumbar traction, first set the table to the cervical position. This allows for easy installation of the traction control unit. Insert the traction unit into the brackets on the base of the table and lower the buckle assembly. The counter traction unit inserts into the bracket at the head end of the table. For lumbar traction, which is directed primarily at the 4th and 5th lumbar vertebrae, you will use the iliac and thoracic harness belts. Place the thoracic harness on the upper half of the table. This counters the traction and keeps the patient from sliding. The iliac harness, the longer of the two, is placed on the bottom half of the table so that the belt is about 5 or 6 inches above the cutout section of the tabletop. Position the patient so that the base of the sacrum is 3 or 4 inches above the bottom cutout section. Put the patient's arms through the loops and buckle the thoracic belt just below the rib cage. It should be snug but not tight. Fasten the iliac harness just above the crest of the ilium. Often this harness will overlap the thoracic harness and should be fastened quite firmly. Next, secure the web strap of the thoracic harness in the counter traction unit at the head end. Generally, having the counter traction bar as far down as possible inside the assembly will provide the correct angle of pull, directing traction to the center line of the patient's spine. To secure the iliac harness, switch the table to lumbar and make sure to turn the poundage all the way down. Only then can you bring the traction control unit up several inches towards the table top. In this position, pull the web strap through the self-locking buckle and take out the slack. The patient is now ready for treatment. To start the table in motion, set the timer for 7 to 10 minutes. Properly position the back rollers so that they rock the sacrum, creating pelvic tilt. This tends to flatten or flex the lumbar area at the peak of distraction. Lumbar traction should be gradually increased in increments of 10 to 25 pounds. Using an adjustable flexion stool will help flatten or normalize the lumbar curve and often makes the patient more comfortable. Adjust the poundage during the rest cycles of the traction, when the table is returning towards the traction control unit. Usually about half the patient's body weight is adequate for lumbar separation. However, it's always advisable to palpate the area, then adjust poundage as indicated. During traction with the anatomotor, you can rotate the patient. Rotating to the right isolates traction force on the left side. Rotating to the left isolates traction force on the right side. Further, you can stop the table at any time to perform manipulation under constant traction. At the end of the treatment, the timer will ring and the table will stop in the rest cycle of traction. Lower the rollers, turn down the poundage dial, and release the harnesses. Let the patient rest a few minutes before getting up. Intermittent traction increases circulation and may aggravate an acute or inflamed condition. If traction is indicated for an acute patient, most physicians would use constant traction. Treatment time should be shorter and poundage lower. Use 2 or 3 cycles of intermittent traction and palpate the affected area to determine the appropriate poundage setting. Then, turn the cervical lumbar table switch to the center off position during the traction pull cycle. Note that the table should be about 3/4 of the way from the lumbar or foot end position. Rollers should be down and ice may be applied to the patient. When the treatment is over, slowly turn the poundage all the way down. Move the table to the lumbar position to remove the harness. A broader form of lumbar traction can be applied using the ankle harness. As before, thread the web strap of the thoracic harness through the counter traction unit at the head end of the table. Wrap the Velcro ankle straps firmly around the ankles. For smaller or more tender ankles, line the harnesses with the rubber inserts supplied. Textbooks refer to this as Buck's traction. With it, the forces of traction can be applied throughout the hip and lumbar area, or they can be isolated to one leg. This can be very effective when treating a patient with sciatica. Feed the web strap through the buckle and push the traction arm towards the table. Treatment time is usually set for 7 to 10 minutes. Now, if not contraindicated, the back rollers should be set. Place the insert block beneath the patient's knees. This will help transfer the traction force to the hip and lumbar area. With the tabletop in motion, slowly increase the poundage over 2 or 3 cycles. The most frequently used poundage is between 1/4 and 1/3 the patient's body weight. Single leg traction, usually to the short painful leg, has often proved effective in treating sciatica. After administering traction to both legs for 2 or 3 minutes, grasp the web strap and unclip the unaffected leg. Then, reduce the poundage to half the previous setting. Treatment may now be given to the affected leg, and poundage may be gradually increased for assisted manipulation. After 5 to 7 minutes, it's advisable to pull on both legs again for another minute or 2. This will help equalize the muscle structure in the lower back. Removing the insert block from beneath the knees will increase traction in the hip and knee area. To administer cervical traction, the traction control unit needs to be inserted at the head end of the table. Remove the pillow and make sure your poundage is turned to the lowest setting. The cervical traction device fits into the bracket on the table top. Switch the table to the cervical position and insert the short T-buckle into the traction control unit. With the insert pad facing the ceiling, position the patient's occipital region into the upper inside ridge of the cradle support. Tighten the tension knob until the patient feels a slight inward pressure. Secure the forehead strap and pull the web strap firmly through the T-buckle assembly. Set the timer to 7 to 10 minutes. Adjust the upper set of rollers to relax the thoracic area during traction. Adjusting the variable speed to 7 or 8 seconds of pull and release is recommended for patient comfort. As the table comes back to the relaxed position, slowly increase the poundage. Usually 10 to 30 pounds should be sufficient. You can palpate the cervical area and feel a slight separation. When treatment has ended, the table will stop in the cervical position. Release the tension from the T-buckle and loosen the tension knobs on the cradle support. Assist the patient to a seated position. To use the head halter cervical device, insert the T-buckle into the traction control unit. Usually the T-buckle should be lifted to its highest position, since this angle will direct more pressure into the occipital area. Clip the head halter to the bowspring with the clip facing out, then hook the bowspring up through the eye bolt. Place the pillow about 5 inches from the top of the table. The top of the patient's head should be at the top of the pillow. Cover one of the white pads with a tissue and insert it into the chin pad. Have the patient hold the chin pad so that the seam bisects the chin. The Velcro strap helps contour the chin pad to the patient's face. Grasp the straps on either side of the small occipital pad and slide it onto the patient's head. Hook these straps to the sides of the chin pad and tighten both sides equally. Standing at the head of the table, push the traction control unit forward and tighten the occipital straps on either side of the patient's head. This is important because only now will most of the pressure be transferred to the occipital region. Set the timer and raise the upper set of rollers to help relax the upper thoracic region of the patient. Patients new to cervical traction may be tense, so 10 to 15 pounds is usually sufficient for a first treatment. Palpate the cervical region as you dial the poundage. If greater pull or longer treatment time is indicated, it's advisable to increase these over several treatments. For constant traction, turn the table switch off during the pull cycle. Under constant traction, the patient has a full range of motion. So rotation is possible and manipulations can also be performed. After treatment, move the switch to the cervical or rest position. To remove the head halter, lift and twist the clip, then remove the chin pad. Lengthen all but the bowstring straps and remove the harness. Allow the patient to rest a few minutes before rising. For passive shoulder exercise, after testing the patient's range of motion, attach the ankle strap to the wrist. Then, with the table switched to cervical, thread it through the T-buckle. To keep the traction unit from moving, set the poundage to 20 to 30 pounds. Now, turn on the timer and slowly increase the patient's range of motion by drawing the strap further through the traction unit. The patient's other hand can assist as the treated arm returns. Over a 10-minute period, the patient will experience about 80 uniform movements. Passive exercise may also be applied around the bicep to abduct the arm. Traction to the elbow or shoulder can also be applied by transferring the traction unit to the foot end and pulling down on the arm. For arm, shoulder, or upper dorsal traction, attach the gripper bar by threading the web strap through the T-buckle. Set the timer to start the table and adjust the bottom set of rollers. Dial a comfortable poundage level for the patient, usually 1/4 to 1/3 of the body weight. Position the patient so that the sacrum is below the table opening and the arms holding the gripper bar are fully extended. Since the patient is lower on the table, these rollers will now treat the upper thoracic area. To treat scoliosis, use about half of the poundage needed for bilateral traction. Then slide the gripper bar to the side of the patient's concavity. This applies unilateral dorsal traction to that side. Because the patient will tend to inhale during the pull cycle and exhale during the rest cycle, additional benefits in lymphatic flow and enhanced respiratory function are often achieved. Hill Laboratories has been a leading manufacturer of chiropractic, physical therapy, and medical treatment tables since 1945. For questions and ordering, call us toll-free at 1-877-445-5020 or visit hilllabs.com.